This conference will now be recorded.
Go this way. I don't know how to.
Okay.
That's okay. It's okay. Don't worry, it's okay. We'll keep a little social distance. I'll try my
Okay.
best. So I'm gonna take a look at the PowerPoint maybe. Yeah.
Yeah. Okay, you're all set. Go ahead whenever you're ready.
Okay, I'm good. So, okay, thank you, everybody. This is Henry Lai from WashU. I'm going to provide some training for the QST part of the project. This is Project B, and the way I think we will do this is I will kind of just briefly go over a PowerPoint that kind of summarizes the manual operation. But really, the key is to really be familiar with the manual operation and kind of do the way it was described at the MOOC, because I may not be able to go over every single details of the MOOC with you. And you can always ask me questions either today or in the future if there's any questions, because I think there will be some along the way. I got Pat here. Hi, here we go. Hi, Pat has been doing QST for a while. We have been running this protocol on 2 other NIH studies, the PinPrick and the pressure algometer, and she have done it and quite familiar with the procedure. We adopted this to study our overactive bladder patients and LURN 2. So there will be training videos that will be showing on the computer today. They are also available at the LURN website that you can get access to. Be a little aware that when we did the training video, it was actually done for a different study. So you might see some mentioning that we are doing this on the side of your stent or something like that, because we were doing this when we developed the video. It was for another study where we put a stent into the patients and we did the QST, but the actual procedure, the way you do it is exactly the same. So when you do the actual testing, I think you follow the MOOC, and there are some descriptions on what to say to the participant in the MOOC, and then we will have Pat kind of show you the actual device and also give you some tips on kind of how to handle the devices and how would be in her experience the best practice to do that. Now we got a number of study coordinator here. Maybe we'll just go around and have people say hi to each other and tell us where you're from. Okay, so let's start with Pat.
Hi, so I'm Pat, and I'm one of the coordinators working on this study with Dr. Lai in St. Louis.
Yes,
Washington University.
And then we got Alex here.
Hi, I'm Alex. I will be helping Pat on the project.
Okay, and I also saw Linda. Linda is on the phone. Linda is also one of our study coordinators. She also is quite familiar with the QST testing. Good. So how about Mary? You want to introduce yourself to us? I'm sure everybody knows who you are.
Yeah.
Hi, this is Mary from Iowa, and I too, like WashU, did the QST and algometer testing in another study, so I'm pretty familiar with it also.
Yes, thank you. Yes, okay. Who else do we have?
This is Falayan Moorhead from Duke. I have not done the any urogyn related studies before now, but I'm interested in learning more as we go. So I will be doing the QST primarily for our study, and we also have a coordinator here who will be like a backup.
Yes, absolutely. Yes, it is actually much easier than you think once you have done a little bit, and you can actually practice on your colleagues. That's how we did the training video. The other person is not a participant; is actually one of our other study coordinator. Okay. Who else do we have?
Hi, this is Pooja from North Shore. I have never done QST, so I'll be paying very close attention, and I will be practicing on my co-workers.
And have them practice on you too, so you know exactly how it feels. It kind of sounds a little bit scary to people when we tell them that we're doing like experimental pain testing on you. But honestly, it's not that painful. It's like nobody's jumping off and screaming. I tell you, it's far from it, right?
Yeah, we don't really want to hurt them, but we just.
Yeah,
They,
yeah. Mm-hmm.
We always tell them that we'll stop at any time, if there's anything that makes them uncomfortable. So yeah, I'm always clear about that.
Yeah.
Don't want to hurt them.
And the other thing, Pooja, is that, Northwestern is actually one of the sites that have done similar type of QST on the MAP study. So if you talk to Jamie,
Yes.
I don't know if the study coordinator from the MAP2 study is still currently there, but they have done this on more than 100 people.
Okay.
Similar. Yep. Mm-hmm, mm-hmm.
Thank
Okay.
you, sir.
Yep. Anybody else? Are we good? Okay. Okay, so I think we will just start off doing a very, very quick PowerPoint. And Melissa, you can advance this for me. Let's go to the next page. Okay, so this is something we went through during the steering committee webinar, but I'm going to just very briefly go over. So the purpose of the QST, which stands for quantitative sensory testing, is to provide physiologic understanding or measurements of the mechanism that underlies the symptoms that our patient has been reporting. Specifically, as you know, in LURN 2, we're studying patients with urgency without UUI. Specifically, we'll be looking at the role of central sensitization, which is a physiologic phenomenon going on in the central nervous system that basically you could think about the central nervous system as an amplifier in your body's sensation. So your nerves in the bladder get the sensation of the urge or bladder filling. It goes through your nervous system in your spinal cord and your brain before the patient interpret the sensation of urge or urgency or sudden urge to pee to go to the bathroom. So the nervous system is actually an amplifier in that sensation that your brain interprets. So what that means is that any process that amplifies that signal more than is usual, for example, there's a pathologic phenomenon called central sensitization where that signal is being amplified. The gain of the system is turned way up. So even a very small amount of bladder filling will give them a strong urge to urinate because the nervous system is not functioning properly, is over amplifying the gain of your amplifier, of your loudspeaker, so to speak. And people feel a sudden urge or very, very intense urge to urinate, even at very low bladder volume. So QST is actually one of the standardized way that we could measure central sensitization or the sensory processing of our nervous system to see if there is abnormalities in our patients, explaining why they have such an intense urgency or not be able to control the bladder, even though we didn't feel the bladder much at a pretty low bladder filling volume. So QST essentially is a protocol that we designed to measure it, and the key to this is what we do this in a uniform manner and in a standardized manner so that we get as objective as we can. This is particularly important because we're doing this across all the sites. There will be multiple study coordinators across the network doing this, patients coming from different geographical locations. We try to standardize the testing as much as we can because this is a multi-site study. So this is the key. That's why we have a manual operation to tell you kind of how to do it and to follow it as closely as we can. The area that we'll be interested is obviously the suprapubic area, which is the area, if you don't know what suprapubic is the area above the bladder. It is kind of in the midline below your belly button, which is where your bladder is. That's where a lot of the people complaining about the abnormal bladder sensation. That's the testing site. We always have a control site, so because we are testing our testing site compared to another site in the body, which is, in this case, is a forearm, which technically would have nothing to do with bladder sensation because it's so far away from the bladder. So for everything we tested, there's a testing site and there's a control site because each individual will actually serve as their own control when we do the measurements and when we compare the data. And we will use two paradigms to study the patients. One is what we call the PinPrick stimulator to look for a response to repeated stimulation. The second one is the Algometer, which is a handheld pressure dial to look at the sensitivity to mechanical pressure. So let me just kind of briefly go through this. Let's go to the next slide. You have also seen this before. It's just important to remind yourself, you know, the study coordinator should follow a manual operation as closely as we can and do not alter the procedures and the sequence of the procedures because we need to maximize uniformity across all sites. This is very important. You should pick one main study coordinator at the site to do QST. A lot of sites will have multiple study coordinator. They should all be trained before they do the QST, but it will be preferred that you pick one main person. We understand there will be backup situations. You know, people will be off and busy and may have more than one study participant. So it's okay to train other people, but try not to have like 5 people rotate and do the QST because there's, despite following the mood, there's still going to be some personal variation. So among the people that you do the testing, try to be as uniform as you can at the site level. You should always do QST in a quiet room. You know, if you're doing this in the clinic, you might want to close the door and make sure there's no disruption, distraction, or noises. You need to do what we call the familiarization procedure prior to the actual testing. The purpose of that, as we could show you later, is for the participant to look at the device, to feel the device. We would do some test stimulation on the device so they anticipate, you know, what the testing is going to be like. So the reason doing that is we want to ease any potential anxiety. You know, some people may be very anxious. They don't know what to expect from the testing. That gives them a sense of what to anticipate and expect during the testing. And it's kind of like a dry run. We won't record the data from the familiarization procedure, so that's not part of the data, but it's important that you do it so that the participant kind of know what to expect, because if people drum up with the anxiety, the first moment you touch them, they'll have the pain rating of 100. That will be Do you find this useful? I mean, Pat, like,
the familiarization?
Yeah.
Yeah, because I mean, I like to explain to them what the instrument is. For example, the PinPrick device is, I hope everyone has theirs by now, right? So they can kind of see it has a sharp tip, but it doesn't puncture the skin, obviously. And it's kind of weighted. So I like to just show them that. I usually don't have them hold it in their hand.
No, they will break it.
Yeah,
they will play with it. You don't want them to play
it.
with it. Yeah, you don't want them to play with it.
And you don't want it to get bent or anything, so it doesn't slide back in there like it's supposed to. But yeah, I usually do just show it to them, and you know, and then the familiarization, obviously, just to show them what it's like. They're pretty good with that.
And then
and the same with the Algometer. I just show them that it has like a soft rubber tip on the bottom, and that I'm going to press it on their skin. And I always reinforce, like, if anything's really uncomfortable, obviously we'll stop whenever you say. But that's what I just show them that.
Yeah, it's not sharp. It's a rubber. It's a rubber.
Yeah, it's a rubber tip, and everything is sterilized beforehand. I always tell them that too.
Yeah, and we will ask them to rate the pain. I don't think it really hurts them that much. That's why I think you encourage yourself to try on your coworker and have them try it on you, so you personally kind of know what to anticipate. It can get a little bit uncomfortable, but nobody is screaming in pain. I don't think that ever happens.
Not maybe if they have a very sensitive bladder. I mean, they don't. We never let it get that bad that they'd be screaming, but
right, yeah, but I think they're pretty tolerable, to be honest. Like we designed a protocol that, you know, we have done this on other folks before in other studies, so I think it's pretty well tolerated among the participants. Let's go to the next page. Okay, so this you should already familiar with. You know, people that has already been enrolled in Project A will be approached by to participate in a QHD study. So we'll have 3 groups. You have the urgency without UUI, the urgency with UUI, and the controls. And the protocol will tell you how many men and how many women will want from each of the 3 groups at your site. And so the DCC will provide some guidance on you know, how you actually fill up the cells and what your progress is. The inclusion, exclusion, and defer criteria is pretty much the same as Project A, with some additional considerations, with some exception. For example, participants cannot be taking anticoagulation medications. We're specifically referring to things like coumadin and warfarin. They can cause bleeding potentially, but you know, I'm not sure that actually happens because there's really no puncture, or you know, but we don't want them to walk away with a bruise.
Any bruising, yeah, right.
But if they take aspirin, Plavix, and Tylenol and things like that, that should be fine. Very obviously, they cannot have an open wound over in the testing area, you know, a big rash, or you know, somebody have surgery and in the abdomen, you're not going to push on the scar. So that may be something you want to look for. That's pretty uncommon, to be honest. Unless they have a big midline scar, you know, below the belly button all the way to the pubic bone. For example, I presume they have a hysterectomy with an open incision, kind of a midline directly over that area. You might want to avoid that participant. So an examination could be useful, or any kind of, you know, history would be useful. But is it laparoscopic surgery or robotic surgery? There's no major scarring over the suprapubic area. We'll show you a picture later on. Then that should be fine. There are certain things that may potentially interfere with testing, so we try to have people to stay away from. For example, pain medication really does decrease the pain rating. So if they take pain medication or sedatives, that includes things like, you know, Valium or Xanax, as a benzodiazepine, as a sedative, we want them to wash out a week before the procedure. If they don't do it, then they cannot do the QST study. I think this is relatively rare. Is that right? Have you come across a lot of patients taking?
Not really. No.
Yeah, benzos. Yeah.
No.
No. Okay. But that would be important. If they cannot wash out, they will have to be excluded. There are also other things that may potentially influence the testing, but it is not that critical, put it that way. For example, if they take NSAIDs or Tylenol for pain, they take muscle relaxants, decongestion, Sudafeds, so they should be held for 24 hours prior. They should stay away from alcohol for 24 hours prior to that. Nicotine and caffeine for about 6 hours. So if they're coming in the morning, I guess you tell them not to drink coffee after midnight. I don't think anybody would do that, but
Well,
maybe not
yeah.
avoid the morning coffee if they're coming in for the afternoon. I don't know.
Yeah, we didn't really do that for MAP, did we? I don't recall that.
Yeah.
Asked that.
But even if you don't, either if the participant is not compliant, we can go ahead and proceed and call this like a protocol deviation, because I don't think it's really that critical as the pain medication. The opioids, we don't want them to be taking real pain pills. That includes tramadol too. Okay. Any questions about that part so far? Okay, let's move on to the next page. Yes.
If you have a patient on lab,
Yes.
there a threshold to which we should do the pressure testing? I mean, should we just, is there a certain point beyond which we shouldn't? We had a patient who developed a hematoma on the forearm.
Do we have a maximal pressure?
I mean,
The threshold, is it a 5? Is it max? I can.
There is no max on the threshold as far as I know.
Okay.
The threshold is as far as the patient can tolerate. So if they start having pain, we stop.
Yeah.
But for patients on Plavix, which they're allowed in the study, should there be?
Maybe we can operationalize that. Maybe there should be a max for people taking Plavix. For other people, we don't.
Right.
Yeah. Most people have pain at what level, you think?
On the forearm?
There's so
The
much.
abdomen and the.
It does. It varies so much.
Yeah.
It's so hard to say.
Okay.
I mean,
It kind of depends on a lot of things.
I ran out of scale.
On the, it kind of depends. Like if people have like extra
Fat.
yeah, they have a little more cushion and they they don't tend to feel it as quick as a thin person. And if they have bladder pain already, obviously that's gonna, but some people have like a real ropey forearm that, you know, that can be kind of painful, just depending.
Okay.
But
we'll contemplate the idea,
Yeah,
but
yeah.
as we speak, I don't think there's a maximal threshold. Melissa, is that right? I don't think there is one at this point.
No, we don't have one.
Okay. So that's something we can think about, but that will be pretty rare. But that's a good point. Testing sites, like we said, the area that we are mostly interested in testing is the suprapubic area, which is that little blue dot here you see on the diagram. And the control site is going to be the forearm, kind of halfway when you extend your arm, when you pronate, I guess it's halfway on the kind of the muscle of your forearm in the middle. There was a question asked earlier whether or not it matters to the left side or the right side. I don't think it really matters for this study. It's kind of depending on how your room is probably set up in a certain way. You just want to be able to get to the forearm comfortably without you bending over and hurting your back or doing something like that. So the handiness really doesn't matter whether or not you do the left or the right as a control arm. The bladder is in the middle anyway. So the forearm side should be pretty obvious to people. It's halfway between the wrist and your ankle. Elbow.
Yeah, okay. You were close.
But the suprapubic area, it is not that difficult. But what you would do is this is like the bony landmarks of the patient. So in the front, there's usually, if you kind of feel this area, there's usually an area where you could actually feel the bone. If you move your cursor to the area that's that pubic symphysis, right in the middle, yeah. So that's the area you could feel the bone, usually on the patient. So we want your testing site to be halfway between that point and the umbilicus. So that's usually that. It should be pretty straightforward. Is it difficult to identify?
No, I wouldn't say so. That's pretty easy. Just kind of eyeball it with your hand. I mean, I just kind of try to feel where the pubic bone is, and then I can see where their
belly button
is. So
yeah, anyway, halfway between that it should be. It's in the midline. It's in the midline. Now you could also have the patients feel their own bone, right? You don't.
Yeah, I could do that. Yeah, I have done that.
Yeah. Okay. So any questions about the testing site? So those will be the two testing sites. Okay, let's see. I think we are good. Let's move on. Let's go to the next slide.
Oh, Henry, yes. There is a question in the chat. When do the participants complete the additional pain questionnaire specific to Project B?
When do you
Will
have
it be
them?
paper or electronic?
Probably prefer them to do it before.
That's usually
yes. We want them to do it before, because if they do it right after, they may report higher than the usual, because those are kind of things we're asking, like what was your rating within the past week or something like that. I think
And we also, there's a blood draw at this visit, and I don't recall if there is. But anyway, if there's a blood draw, we try to do that after the QST testing, because again, that might give them a heightened rating of their pain.
Yeah. So, but the question should be done before the actual testing. So let's see, where's the chat? Here we go. Okay, we got it. Will they do paper or electronic? When do the participant? Are we doing paper or electronic, Melissa? I don't remember.
I think it's paper for this.
Okay. So they'll do this on paper, and then the study coordinator transcribe it to the LURN link.
Correct.
Okay, got you. Okay. Anything else on the testing site? Questions? Okay, let's move on to the next page. Okay, so for the PinPrick and also for the Algometer, there's three parts to this. There's a familiarization, and there's a forearm testing, and there's suprapubic area testing. And And on the manual operation, there'll be a script that you're going to read to the participant in the little green. You can, do you make copies of this and read it off
Yeah, we have a little, like a little pamphlet thing that we've made that we just read.
Yeah.
Keep it with us.
Yeah, I mean, you could copy and paste so that you could just read it off relatively easily to the participant at different parts of the procedure. That way you won't kind of skip like a step or something like that. And Melissa, when they do this, this is going to be done on paper too, I believe, right? I mean, when they do the rating, they write down a number on a sheet of paper. The coordinator.
Yeah, because I think that's the easiest.
Yes.
Instead of trying to put it in the computer.
Absolutely.
And I know that they are going to have a question for you on this regarding the scale of 0 to 100. Is that, do you find that it's difficult for participants to give you a good number back, giving them that large of a range?
0 to 100 is subjective.
I mean, sometimes people will say, I mean, I have to remind them, they might say, oh, I'm just not used to that, but I can't honestly say I've run into a problem with them understanding that scale.
Maybe think about 0 to 10 and just add a 0 to the end of your number. So if they would normally say, oh, about a 5, maybe add a 0 and make it 50. I don't know.
That's exactly what I was going to say. If we have a person that has trouble with that 0 to 100 and says that what they're used to is 0 to 10, I mean, what I have done is I would say, well, then let's think about it on a 0 to 10, and then I will basically, but if we do that, I always confirm with a patient if they say, well, it's a 5. So I would say, now, do you mean 5 out of 100 or 50? Because, you know, you want to make it clear. But yes, we have, that's exactly what I have done when I have someone who has trouble sort of comprehending the 0 to 100 scale.
Yeah, you know, that's a great question. There's always going to be a little bit subjective, right? Because 100 for you is different from 100 for me, and I don't think I have that many painful episodes in my life. So, do I actually know what is 100 for me? I don't know. I didn't have a car accident or something. Now, in my imagination, can I tell the difference between a pain rating of 57 versus 63? I will be kind of hard pressed that people will be able to tell you to that fine level of detail, to be honest.
Yeah. Now, Dr. Lai, is there a reason why we did 0 to 100 in this case as opposed to 0 to 10? I mean, sometimes, you know, we wonder on these if there is a reasoning behind it.
That's because of some of the other study we just go from 0 to 100. But you could take the approach that you say, I mean, if they have trouble, you could go from 0 to 10, and then you just multiply by 10. If it makes it easier for them to understand, instead of like telling you 57, they could tell you 6, you know, 6 will be 60, but you will confirm it with them before you put 60 on there.
Right.
Sounds fair?
Yeah, that sounds great.
Yeah.
Okay. Yeah, that's a good point. So let's move on to the next slide. Okay, so this is kind of the sequence. The protocol will spell it out. Essentially, for the PinPrick, you're going to stimulate them one time, and then have them rate from 0 to 100, and then give them a little break, and then you will do it 10 times in the sequence. You want to do this within kind of a very small area within a centimeter. So you don't poke the same point over and over again, but within the same 1 centimeter area, right? The point is to see if the pain get exacerbated, if they get 10 stimulation in that area is once per second. So you use the little, you know, the metronome to time it. And I think it may be better to have you wear a headset so you hear the thing without distracting them, because I think it could distract them if you're poking and them hitting the beep, beep, beep at the same time. So after 10 of those, once per second, you're going to have them rate from 0 to 100, and you give them a little break, and then you do this 3 times. So you get one number here, 0 to 100, second 0 to 100. So you got 6 rating. And then after that, you wait 15 seconds later, have them give you the pain rating from 0 to 100. That's called after sensation. kind of like after you run, you have your peak heart rate, and then we can see how fast the heart rate drops back down. So 15 seconds, you ask them to rate the pain from 0 to 100, and 30 seconds later, you ask them to rate the pain from 0 to 100. Again, you can print off the case report form, so you could write down the numbers as you move on. It's better that way, so you don't kind of forget to do a certain procedure or kind of do the procedure in the wrong order. If you just follow your case report form and then just follow and write down the number, the next thing to do, write down the number, the next thing to do, then you would not make error. Does that work pretty well?
Yeah, and that also, if you take time to write down their responses, then that gives you the pause that you need between each set, sort of. Does that make sense?
Yeah, I think so. And so in a nutshell, that's kind of what the PinPrick protocol sequence is, and you don't want to change the sequence. Let's move on to the next slide. And maybe we could show, you want to show them the PinPrick first before you show the video?
Yeah.
So I'm going to have Pat show you the PinPrick, okay?
So this is the PinPrick. It's got a sharp point, but it doesn't break the skin because it's weighted. So like if I press it on my own arm, that part retracts. So it just gives me a sharp sensation on the skin, but it doesn't puncture. And some people don't like this at all. They think it's just, I don't know if anyone ever really says this is super painful. It's just kind of like,
it's a little annoying.
It's just annoying, yeah.
But it's
kind
not,
of gives you the willies.
Right.
But,
it's not.
Just so everybody knows that's not where we'll do it.
That's right. You're right. I just thank you.
So you can see.
Yeah, I just holding it up so you can see.
I know, Pat.
That's okay.
And it kind of is calibrated so that when the pin retract, it deliver a specific amount of force to the skin. That's the way it's kind of being standardized. And yeah.
And you let it take like a full second to compress it. Yeah, it's like, and you hold it straight up and down like this on the skin wherever you're doing it.
Okay. Okay, so maybe we could show a video. This is kind of the video for the forearm. Maybe you guys can see. Okay. Can they hear? I don't think they can hear. At least I cannot.
I can't hear it. Yeah. That's what he's asking.
Yeah. So yeah, if we can make it to work.
So you do 1, and then ask for a pain score, and then do 10 in a row.
You do this once per second according to the method.
Yeah, that might have been a little fast.
The video is kind of.
Yeah, maybe so. I don't know if that's.
It may be the internet thing, but you do this once per second, and then you ask them to rate it from 0 to 10. Do you want me to try 0 to 100? Yes. Do you want me to share your screen and maybe I can pull the video and try? You want to do that, Melissa?
Yeah, if you want.
Okay.
Or actually what I can do is we can play it again and I'll just have my speaker on. Maybe that's why it's not hearing. Sorry.
Next, I will do the actual test to your left forearm because your stent is on the right side.
Okay, ignore the stent part.
Quickly, 10. Pain score, please, 30.
Okay, that's kind of how it goes. There's the 1 rated 0 to 100. There'll be a sequence of 10 rated 0 to 100. You repeat it again. Okay, any questions on this part or any practical tips or anything that?
Zero.
I had a question for Pat. When you're using the pinprick, are you pressing it down or are you letting it naturally retract? Like how much force are you putting when the needle is down?
I just hold it kind of gently in my fingers like this. So I don't really press down. It just kind of, and the pinprick is kind of heavy. So I have to hold on to it so I don't drop it, but I really just kind of, yeah.
There's no resistance.
Yeah, there wouldn't be much
Yeah,
gain by pressing down.
Freely.
Yeah, like if I hold it lateral or down, the point is down, but then if I do like that,
It just
it
retracts.
retracts.
Yeah, once that small amount of force is delivered, it will automatically retract. So you could just do it very gently.
Yeah.
It will kind of just do that. You don't need to force it
Yeah.
down. That wouldn't do
Right.
anything, and you don't want to do that. I don't think you can
Right,
damage it if you're too.
The needle would just, all it would do is like completely retract and it'd be flush on the skin. That's all that happens. So, does that make sense?
So the purpose is not to press it all the way down. You just want to tap the skin essentially for half a second.
Yeah, you don't necessarily, I don't always make a point of pressing it all the way down. Just,
You don't have to go all the way.
just like,
Once it start to retract, I think it's already delivering the force.
mhm.
And by the time you kind of lift it up, that's kind of your half second, whatever, because it does take time to go up and down.
It does.
Yeah.
Yeah, hi, this is Pooja. I just had a dumb question. When we have that area of 1 centimeter, does it matter if you have the pinprick in the same area a couple of times, or it has to be spread out?
Well, it's pretty hard to be super precise with that. I think the whole point is just to keep the pokes like within a small area, so you're not spread around too much.
Oh, okay.
But I don't know how
You don't need to keep track.
Yeah, I don't think
Kind of just in your area.
Yeah.
You don't want to be poking the same spot over and over.
The exact same spot, yeah. But if it happens,
It's fine.
It's going to happen.
It's going to happen.
But are you asking, Pooja, if you have to do a series of 3, is that all done in the same area? And the answer should be yes, correct?
Yes.
Yes.
Okay.
Oh, good point. Yeah.
Like a penny size.
Yeah, 1 centimeter.
Yeah.
Like a little. Yeah.
Can you repeat that for me, please? I was going to write it and then I missed it.
Well, I think I don't know. Were you asking if the pinprick device pokes in the exact same spot on the skin? Is that a problem, or were you asking if all of the sets of pricks have to be done in the same area?
The second one.
Okay, they do,
Yeah.
and that is true. In the same 1 centimeter circle area.
Yes. Oh,
Yes.
Okay, thanks, Mary, for clarifying.
Well, the only other thing I was going to add to this was at the end, the after sensation, when you check at 15 seconds and 30 seconds, that can be anything. It doesn't have to be pain necessarily, does it? Because I thought it was any sensation.
Any sensation, because at that point, you're not really poking at them anymore.
Right.
Hopefully, they will be kind of using whatever frame of 0 to 100 that they conceptualize and give you kind of how
Right.
that sensation decrease. But yeah.
Okay.
Right.
We'll let them kind of decide how if they end up being a 60 at the last, series of 10, and then they probably will end up telling you 30 or 0 or whatever.
Yeah, or just nothing, yeah.
Yeah,
Usually not much.
lower.
Right.
Any questions on PinPrick before we move on? So let me see. I think we have that questions. Okay. We'll go on to move to the pressure algometer. This is the pressure device. Okay, I'm going to have Pat show you the device. First, there's a button, and I think there was some confusion about that little button. You want to show them the device first of all?
Yeah, so this has a little rubber tip on the end, and what you do is you want to press it on the skin. I'll do it on the inside of my wrist, but it's so you just get the idea. So you press it down. I can do it. You press it down up to the pre-prescribed amount. Hold it for 5 seconds and then release it. And then when you want it reset the device back to 0, you just hit this little button here. And then it goes back to 0. Does that make sense? So
let's see, maybe you could turn it this way so they could see. Okay.
So we press it down, and you want to keep it like kind of level. You don't want to push it too far to one side or the other, and I can't really see how far I'm pressing. He didn't say anything, so I
Facial recording.
yeah. And then you can reset it. And
And then you're reading the inside of the dial is a kilogram, because you could kind of see there's two scale. The one on the outside is the pound, the one on the inside is a kilogram. And when you read the protocol, we want 2 kilogram and 4 kilograms. So you look at the inside of the yellow instead of the, because if you look at the outside and kind of get confused, then you're really not delivering the proper amount of pressure.
And of course, you have the little metronome counting in your ear. So we were always told to press down about
5 seconds.
Like 2 seconds to get up to the 2, for instance, and then 2 more seconds to get to the 3.
Okay. So let me just kind of go through this very quickly with you. It's the same kind of procedure. There's a familiarization. You do it on the opposite forearm, opposite to the side that you're testing. And then you do the forearm testing, and then you do the suprapubic testing area at a similar site before. You may not want to go back to exactly the same spot, kind of move it maybe a little bit away from the pinprick, if you even remember.
True too. Yeah, sometimes you can still see the little red mark from the pinprick.
And then you read the scripts. You know, there are 2 different scripts because they're different, 2 different parts that we're doing. So let's move on to the next page. I think this is actually the more important part. This is delivering a set amount of pressure to the area for about 5 seconds. Then you ask them to rate the pain from 0 to 100. And then after that, you release it and then press the button to reset it before you go back to the 2 kilogram again. So we do it as a sequence of 2 kilogram, a little break, 2 kilogram, and then 4 kilogram, and then 2 kilogram, 4 kilogram. So we want to do it at exactly that order. We don't want you to change the sequence and kind of do it that way. And when you press down, you try not to have this is kind of the imprints from the rubber stamp. You don't want it to be like the same spot over and over and over again. You kind of want, just like the pinprick, you want to kind of be in the same vicinity of the area that you are pushing down for. For example, you could do like the first one here. The second one, just kind of move it away a little bit, but overlap a little bit. And then the third one, I mean, it doesn't have to be that pretty or precise. You just don't want the same rubber thing to do this at exactly the same spot 6 times. And they are really asked to rate the pain or discomfort, I guess. Not necessarily the pressure of the probe, because they will feel some pressure of the probe because of the way we kind of pushing it on a plastic piston. Have people have difficulties? I would imagine some people may have some difficulty distinguishing the 2. Have you noticed that?
I always tell them that. I want them to make a distinction between pain and pressure, because it's very important for the study. And I I don't really think that's difficult for them to understand. It would,
Nobody like have a lot of
I
questions
wouldn't
about like what
say
is
so.
no,
Yeah, I wouldn't
no.
say. I think it's
No.
pretty straightforward.
It's pretty straightforward. Can you go back to the last slide on the PowerPoint? Okay, so yeah, we did try to, let's see.
I think the
Yeah.
instructions that we read
Yeah.
are helpful.
Yes.
Yeah,
Oh, yeah.
for example, first I'm going to start with your forearm. After each pressure, I'll ask you to rate the pain intensity from 0 to 100, with 0 representing pressure but no pain, and 100 representing pain as best as you could imagine. Remember, if it just feels like pressure but not pain, rate 0. So we try to clarify this with the scripts.
Right.
And I guess that helps. If the test becomes too uncomfortable, please let me know, and we can stop at any time, and a total of 6 pressure will be applied. So hopefully that will try to ease it. Mary, did you have problem between pain and pressure when we do this part for participant two?
I did for some that didn't understand it, and I would just tell them if the pressure became painful, then you rate that pain.
Yes. Okay. Perfect.
And,
Yeah,
and that's about all I could tell them.
That's what we do with the threshold too, is that you make a distinction.
Mm-hmm.
Yeah.
So let's move to the next slide. So that's the first part. This is applying a set amount of pressure and have them rated. So you got 6 rating. Now this is called what we call the ascending pressure threshold. Basically, this is a little different. You are going to increase the pressure at about 0.5 per second. So is that
Yeah, that's like what I was saying is when you're counting with the metronome in your ear, as you're pressing down, it's about let's see, it's half.
So it takes 4 seconds to get to 2.
Yeah, you count like 1001, 1002, up to the 2. So in other words, by the time you get up to 4, that could be that's 8 seconds that you're counting.
You kind of just, I think you may have to kind of practice a few times on. So the idea is that we're going to apply an increasing amount of pressure at a somewhat, predictable rate. At this case, is 0.5 per second. That means 1 second later, it will be 1, 1.5, 2, 2.5. So you keep increasing the pressure until the moment they say, okay, it hurts. And that's it. You write down that number. Right. You lift up the device, you look at the device and see what pressure that is, and you write it down. It could be 3.4, it could be 2.5, it could be 5. I think it's rare for people to go off board, but there is a spread. I think you will see some variability on people for a number of reasons, because some people might tolerate pain better than others. Some people might just kind of hold as long as they can, and other people just like at the flick of the coin, the discomfort they would tell you. It's also the amount of body fat that can vary in the suprapubic area, less so in the forearm, but the suprapubic area, there's some body fat. So sometimes you got to push harder or further in to get that kind of pain sensation. So you would see some variability over here. When we do this, and then you do this 2 more times. This is a little bit difficult for you. It takes a little while to learn that pace, like how to increase that pressure.
And then you also have to remember when you're doing the threshold, like you're pressing until the patient reports that it's painful, make sure that you don't push that little button to clear the scale until you write down that number, because otherwise you won't know what your number is.
Right, once you push it, we go back to 0.
Yeah.
And this one is a little different than the previous study in that we use the trapezoid or trapezium, whatever you call those muscles. And so this is just going to be done on the arm. It's not going to be on the abdomen, correct?
It'll be on the abdomen.
On the abdomen also. Yes.
Okay, this is a little different than before, so it's new to me.
And I think you will see some variability. We have done similar stuff before, not in the map, but for a different study. You might see some variability because people that are really obese with a lot of fat, they could take quite a bit of pressure before they start to say I have pain.
It's true. Yeah.
Yes.
Yeah.
You know, I also tell patients that this is not the time to be a hero, that I mean, that it does not become part of their record, that we want true results for the study. Some of them feel that, you know, this is the time to show how tolerant, you know, they can be of pain. So I don't know, but we have had patients, particularly men, that will go all the way up to 10.
On these muscles especially. On the shoulder, but that's not what we're doing now.
In the stent study, so.
Yeah, I always say don't underrate your pain.
Yeah.
Make sure you're not underrating it for any reason. You don't have to prove anything to us.
Yeah. So there are different kind of things that we do. What we chose to do is what we call pain threshold. That means at the very moment they feel like they have pain, they reported it to you. There are other ways to test it that we're not using it in LURN. There's what we call a pain tolerance. That means we push until they have pain threshold and they start having pain. We keep pushing until they say, I cannot take it anymore. That is called the pain tolerance. That's kind of what we're referring to. I am the hero. I'm going to take as much pain as I can that I cannot take it anymore. That's not what we're measuring here. So yeah, we actually want, you can do it, but we can do it in other studies, but we don't want it here. We want the pain threshold at the very first moment they feel like they would qualify this as a pain sensation or really discomfort, then they report it to you. That's actually what we're going after. We're not trying to ask them to be a hero and take as much pain as they can. That's not what we're going after. So maybe we can show a video of that. Let's see. Yeah. Okay. Got the speaker on. I guess we still can hear.
Yeah. Melissa can't hear us.
Maybe you can handle today, I guess.
I think that what I'm doing right now on the video is reading that
Reading the script.
Yeah.
Now you're going to do a 2 kilogram.
Right.
Hold for 5 seconds.
Pain score, please. 30. Pain score, please. 60.
We're now going to go up to 4 kilograms.
Yeah.
Press quite a bit.
Yeah.
That's about 10 pounds. 4 kilograms is about 10 pounds of pressure. Go back to 2 kilograms.
Pain score, please. 60. Pain score, please. 90.
Wow. Now, normally I would say, are you sure you're okay with me continuing with this? Yeah, I mean, I was going to say that. And it was Sue, so I knew that she would, but, I mean, I knew she would, yeah.
90.
Okay. Okay, so that's just like the that question.
Right.
Any questions on that?
So I was just going to say, I don't know if they could hear me during the video, but if if the patient gives kind of a higher rating, I usually clarify with them that it's okay to continue. I mean, you have to kind of use your judgment, and I always make it clear, like, we really don't want to hurt anyone, but so please let me know if you're okay with me continuing, you know.
Yeah, if it's like 90 or 100,
90 or
100
like,
over 100, maybe
yeah,
you
maybe we'll
might want to
stop.
ask them.
Yeah. Yeah.
I mean, usually,
have a question. Oh,
yeah.
sorry.
Go ahead.
Yeah, I have a question. I stepped away for a second to pick up my phone, so I don't know what I might have missed. But just to be sure, like those patients that have had like a stroke or mastectomy or things like that, they wouldn't necessarily be excluded. We would just have to use the opposite arm, right?
It not for this. So the ops, I don't think they're excluded if they have a
I don't think
mastectomy
so.
or
I think yeah, in that case, you probably would just use your best judgment.
you
and
would
not
use your best
the
judgment.
affected
I don't think honestly, like if you have a mastectomy, you would not even start an IV on that side if patient's
Right.
having surgery.
Or
So you
blood
might want to
pressure.
yeah, right. So you probably want to do this on the other side as your
Yeah.
judgment because you don't want to mess with that if they have a mastectomy or actually no
So
dissection.
I would really have to kind of ask if they, if they
Yeah,
have only for this project.
you might want to ask if, yeah, I mean, it's probably worthwhile to ask. I don't know how common that would be, but
We'll get a
Yeah.
medical history, right?
we will get
Yeah.
a medical history.
Yeah.
You could
Okay.
look through
Yep.
that and see if they have a mastectomy or breast
Yeah.
cancer. But yeah, I would say from that, away from that side, you could use the other side. You could do the familiarization with the other side. Just pick a little different spot. It's just for them to hold the thing and be familiar. That's okay.
Got it. Thank you.
And make a note, maybe.
Yeah, there's a comment section, I'm sure, on the CRF where you could make a note of that.
Okay. Perfect. Thank you.
Yeah. Hi, this is Pooja. I am a queen of dumb questions today. So the six. No, what am I saying? The six pressure. The 6 points of pressure, and then you're going to keep increasing by 0.5 till the patient says, or till you reach their pain threshold.
Yes. So we will do the 6, the 2, the 2, the 4, the 2, 4, and 4. And then I guess you give me a little break, and then you're going to do the increasing,
And you do the threshold,
ascending, and this ascending was done 3 times.
Right.
So you got three pressures. Yes.
Does that make sense?
Could you repeat that again? I'm sorry.
So there's the set sequence that you do with the pressures. You do the 2 and the 2 and the 4 and the 2 and the 4 and the 4.
Yes.
And then you give them a little break, and then you do the threshold pressures, which is like you press down slowly until they tell you to stop, and they should tell you to stop when it turns from a feeling of just pressure into pain. If it starts to feel painful, that's when I want them to tell me to stop. And then you just release it from their skin, and then you make sure you write down the number that appears on your little dial before you clear it.
Okay, so are we pressing that little button in between those 6 points?
Yes.
Okay.
Yes, each time.
And then,
Otherwise, you wouldn't.
are you moving the site of pressure points after the 2, 2, 4, 2, 4, 4? When you do
I don't
the
go back. I just continue to make some overlapping circles. I don't go back into the exact same spot.
right. I just wanted to clarify that. Thank you.
Yeah, it can be like.
So the threshold pain thing, we are increasing by 0.5 and it's done only once, right? So 6 plus 1.
No, 3 times. You do this 3 times.
Yeah.
So you get 3 different threshold values.
And you increase by 0.5 per second as you're pressing down each time. That's just the rate at which you apply the pressure.
Okay, so Thank you.
Yeah, okay.
It's too bad we cannot meet in person because
Yeah,
we're gonna push
would-
it on your forearm. So it will be so obvious, like
Yeah.
how to do it.
Yeah, yeah. I could press on Dr. Lai's arm if that would help anybody. If he'll let me.
So, is there any more PowerPoint after this one? I think this might be the end.
I have a quick question, Ashley from U of M. So I find it kind of confusing with as far as like telling them when they feel pain, we're going to tell them we can stop or that we're going to stop. But if they're rating it out of 100, if it's anything above 0, I would assume that there's like some level of pain. Are we just like telling them we'll stop whenever the pain is too much? Because what my first understanding was that we were going to stop as soon as they felt pain, but
No,
they
that's
continue to increase it.
Well, yeah, I mean, I always, with any patient, if something is too uncomfortable, I obviously don't want to continue. There's always that, but when it comes to the set pressures, you are actually looking for a pain score. Unless something
Okay.
is too uncomfortable, but you are actually looking for a pain score. But with the threshold, you're just looking for the pressure where it turns from pressure into pain.
Okay, so it's not that we're necessarily stopping as soon as they feel a little bit of pain. We're just stopping
No.
when it's too painful for
No.
them.
The whole point of QST is that you kind of in a controlled manner invoke some level of pain or discomfort for them, so they could rate it for you with different stimulation. So you want to invoke a little bit of pain, but as you mentioned earlier, I think on the script is if it gets too uncomfortable, the patients or the participant would have the option to tell you, okay, we're done with this. I don't want to do this anymore. Then you stop and you write on the CRF. This is not something that it will happen often. I think it's pretty rare that people will quit in the middle because it's too much.
Yeah.
So we because it was designed to kind of have some pain and discomfort, but it's not to a level that a normal people would not be able to take, I think, and say this is too much for me. That will be pretty rare. They have the option, just like any other study, they could say, this may be too much, I don't want to do this, or that's possible.
Yeah.
Yeah, but it would not be common.
Right.
Yes.
Okay.
Right.
Yeah, I had a question. So when you do the pain threshold thing and you're increasing it by 0.5, how do you know when to stop? Will the patient say stop, don't do it anymore?
Right. Well, when they say that it turned from a feeling of pressure into painful sensation, that's the threshold one.
Yeah. So there's a little script if you're looking at the PowerPoint. So for the next 10, I'll be applying a gradually increasing pressure on your forearm rather than having you rate the pain. I would like you to indicate the moment the sensation changed from a feeling of pressure to a feeling of pain. You can say something like pain or now or stop when this occurs. Once you start to feel any pain, even a small amount, please tell me, and that's when I will stop. So for this particular part, this is what you're looking for. So you read this, so I think they should, I think people understand this pretty well.
I think they do.
Yeah.
I think they do.
Yeah.
Thank you, sounds good.
Okay. Any practical tips for people like Pat or Mary or Alex or anybody who have done this? I mean, we've done kind of a variation of this on other participants in different studies. Any particular tips on?
I mean, we've already said, yeah.
Yeah.
I can't think of
Yeah. This is Pooja. I had another not so intelligent question. I could ask it or I could just email it.
No, go ahead. Go ahead.
Okay. So, forearm is pretty okay. There is not much hair on it. But if there is a lot of hair between the belly button, and then does that interfere with the pinprick or the pressure thing?
I don't think so. I mean, the little tip on the algometer is small enough that you know, I think you can avoid some of the hair. I don't think it pulls. I've never had that happen.
No, it won't pull it.
And on the forearm, it's on the inside of the arm like this. It's on this part. So
Oh,
even
yeah.
on hairy minutes,
Hairy,
that's not
yeah.
really hairy.
It won't pull the hair. You can
No.
do this on
Oh.
hairy hair.
Okay.
Yeah.
Thank
Yeah,
you.
I haven't run into that, no.
Yeah. Now, I do want to maybe have Pat just spend a little bit of time. Like, how do you take care of the pinprick?
Oh, to take care of it? Well, it comes in this nice little box, like so. I'm holding it in with my thumb so it doesn't slide around. And then after each use, we have a disinfecting technique, and that's probably in the MOO. You have to buy the disinfectant and keep it up to date, but we just invert it in a little test tube with a stand that we have, just so that the tip is in the disinfectant for 10 minutes. And then we take it out and let it dry, and then kind of close up the box. We just store it in the box like that, and it's got this little lid. And then since we have several people who are using this, we always keep a little log so everyone knows when it's been sterilized last.
Mm-hmm.
And the algometer, we just usually wipe that off with an alcohol wipe. Yeah.
Mm-hmm. Yeah, there's no
Each
specific
time, yeah.
care for that one.
And that comes in a little case too, like this. So, yeah.
The pinprick,
So-
you have to be careful because you don't want to bend the pins. If you bend the pins, or if you kind of doing the test, you feel like it is not going down easily or smoothly, you probably have bent the pin. If that's the case, you might have to get it repaired or may have to buy a different one. That's very important that the
Right.
pin doesn't get bent.
Right.
So be
You
careful.
definitely don't wanna
want to
drop it.
drop it to
No.
the floor.
No.
I wouldn't have the participant even hold that.
No, I don't
No.
know. And actually, we have this box. We've had this box for quite a while, and the latches don't really stay shut on it. So we have these handy rubber bands that we just to keep the box from popping open unexpectedly. So
Because aren't they about $2,000 a piece?
Yes.
I
I have a
right.
Yes.
Now, but I just want to say, if, I mean, life happens, right? And so if you do drop it or whatever happens, you can exchange just the pin mechanism. You don't have to buy a whole new one, but you have to be in touch with the manufacturer in Germany, and they will send you the replacement part. And
That happened.
that has happened to us.
Okay.
Oh, yeah.
Dr. Lyon, maybe not now, but it has happened to us.
We kept it from you.
Yeah.
What's it?
Yeah, but we have, yeah, it's good. We was.
I say it wasn't.
But I mean, it happens. So, and the repair is not as expensive as obviously buying a whole new one. So.
I have a question about cleaning the disinfectant that you mentioned. I actually spoke to the guy in Germany, and they usually don't sell that to a site unless you order a minimum of those stimulators. So he recommended that I find a US grade disinfectant, something straightforward as an alternative. Is there anything that you recommend?
Well, I think that's in the MOO. I think it's a very specific kind of cleaner. It's a disinfectant. We order it from ECO, Echo Labs.
Yeah.
Yeah, that's what we have to use. I don't think. We've
So
never
I
used
can
anything
order
else.
that somewhere else, just not from them, because they wouldn't supply it to us unless we had a minimum order of something. But he recommended that we find an alternative. Okay, so Ecolab neutral. I can purchase that in the US somewhere. Okay.
That's right. Yeah, we bought it. And the thing to know about that is, like, what I've run into is you have to buy a minimum amount, and it's way more than you need, and it expires kind of quickly. So
Can you wash
to,
dishes with it?
I don't know. I have not tried, but maybe you could. I don't know. But it's a whole process of like mixing it in. We get an empty half-gallon water jug, and we mix it in that. And we have to label it and make sure that it doesn't expire, and then we have to call hazardous waste people to come and pick it up. So it's a whole process.
Maybe not, maybe not dishes.
I will
Maybe
keep that in mind.
It could be hard on your hands, I think.
Oh, is that
Yeah,
right?
I think it would.
Perfect. Thank you.
Okay, anything else particular? I mean, you can always reach us for questions.
Sure.
I got my email, and then Melissa can also give you emails for Pat. And I'm sure when you start doing this, there will be some questions, and there'll be like, you know, this patient is a little different, like the mastectomy patients. Sometimes you have to use your a little judgment on that. To when you implement this, but we'll be open to questions if you have any concerns or anything. You can reach us and we could try to address as much as we can.
Okay.
And are we doing this just at our baseline visit?
Yes, one time only.
Okay.
This is a one-time only deal. Yes.
Okay.
And you probably, you know, once this is up and running, depending obviously on your COVID-19 status, whether or not you could do a research study on participants for something like this. When you approach a participant for ops cohort A, you would probably want to mention to them, you know, some QST procedures, and they could opt in to do that, you know, at the time.
Yeah, you could do it at the same.
You could do it at the time, or you could do it at some other time they come back, or I don't know how people wants to implement the ops cohort study, because you still have to do a pelvic exam and other things on them, and this will be a good time to kind of, you know, do the QST if they're coming back. I don't know how people want to operationalize at the site.
Yeah. Hi, I had a question. So you would recommend if a patient is coming for a study visit to do the blood draw after you have done the QST with them, right? You would recommend that, right?
Yes.
That would be better, although I mean it's not. I mean
maybe on the other arm, if you know, you just don't want to do anything that's going to make them have a heightened rating on their pain scores.
Yeah, but the physical exam and the DRE is fine, right? To get it before.
It is okay. I mean, if somehow your operation are kind of the way you structure your blood draw and this and you know, it would not be possible doing that. That's okay. You could write it down as like, I don't think we actually specify on the protocol specifically about blood draw before and after. That's our preference, but
right.
You can do whatever work best for you in terms of kind of the logistics, because you know they may have to send them to the lab. I don't know. Yeah.
Right. Yeah.
Yeah.
Right.
Okay. Okay. Well, anything else on folks? I think we go through this relatively briefly, but you know, if you have any questions, you could ask us and call us and
Sure.
and reach out to us.
Thank you so much.
Thank you.
Okay, thank you. So Melissa, I think that's it. So they can reach us if there's any questions. I'm sure a lot will come up when this happens. Actually.
Yeah.
Thank you.